right. So thank you once again for inviting us to this webinar. It's an honor to have this discussion with you today. And I want to start by acknowledging the organizers for bringing us together. So we're going to make this presentation myself and Professor Elizabeth Bukusi. Professor Elizabeth Bukusi and I work for the Kenya Medical Research Institute. I am a research scientist and she's a senior principal clinical research scientist. She's my boss, so I work under her, and our studies or our research interests focus mainly on preventing HIV and STI infections among adolescent girls and young women in Kenya. So this is going to be we're going to make a presentation for about 30 to 40 minutes and have plenty of time for question and answer. And this is going to be an interactive session, so I hope that you can be able to unmute yourself, ask any question at any point, raise your hand. Yeah, so any of those is okay with us. And then I'll request the organizer also to maybe to be a timekeeper for us. If we go past 40 minutes, to just notify us so that we have adequate time for the question and answer. So what we're going to talk about in this presentation is that we're going to explore the influence of journals in global health, look at some of the authorship patterns from studies that have been done or that have arisen from global health partnerships. And then we are going to offer some suggestions on the way forward, and also some of the things that we have done on our end to make our partnerships more equitable. So to start off, just as the name suggests, global health partnerships rely on collaborations between individuals and institutions in high-income countries and low and middle-income countries. For low and middle-income countries, this is crucial because of low spending by their governments on research. And on average, governments in low and middle-income countries spend less than 1% of their budgets on GDP. I mean, less than 1% of their GDP on research, and not just health research. This is research across board, and they face many fiscal strains. For example, right now we all know about the challenges that countries are facing in their monetary ecosystem due to the inflation that's brought about by many things. So these governments are usually forced to cut spending that's considered social spending. Part of these are things like research spending and probably prioritize debt servicing. So these partnerships are important and they have the potential to improve the health of people and the health policy landscape in low and middle income countries. However, there are significant power differences that exist between researchers and institutions in high income countries and those in low and middle income countries. And this power difference can lead to unequal opportunities for local researchers who participate in such collaborations. One way that this manifests is in publications being authored mainly and in some cases exclusively by researchers from outside the country where these studies are done. And this practice deprives investigators from low and middle income countries of equal opportunities to build their research portfolio and attendant benefits that come with it. So journals and by extension authorship, and especially in the top-rated journals, is an important instrument of soft power in global health. And in global health, power can be exercised in different phases of where projects fall. They could also it could either be research, could be implementing programs from research that from evidence from research that has already been done, and also when influencing policies. And it's often the case that global health practitioners and their work focuses on reducing the burden of disease and promoting global health solidarity. But it is also true that global health practitioners do gain global recognition as experts in their fields based on their publications from global health work, and are recognized as humanitarians based on the same work. They are able to secure leadership opportunities in global health institutions which are well funded at this time, to obtain job security, e.g. tenure for academics in some jurisdictions that award these based on authorship, and also acquisition of resources and prestige for the institutions from grants, from endowments, and also that researchers in global health do advance national interests, and also sometimes that they do profit financially. So why is authorship an important thing? First, global health, the research or the gaps, the things that global health addresses, these questions are usually sourced from gaps in literature. And gaps in literature means that we have to go to research databases, and therefore it means that you are identifying gaps based on publications that have already been published. So authorship is important because the questions that then researchers in global health are going to focus on are those gaps that are identified from these studies. And most of these databases are found or are domiciled in high-income countries, and by extension, therefore, most of the studies that are included there are by researchers from mainly high-income countries, as we are going to see in a few slides on statistics. And even the foundational text, sometimes when you're identifying a research gap, then there are those foundational researchers in that area that someone may ask you, how can you be talking about this issue when you not referenced certain key researchers who are recognized in that field? So in that case, mainstream journals therefore have a direct influence on what is researched. The other thing is that journals and a person's authorship portfolio influences whether we consider them to be experts in their field or not, and therefore whether we accord them the level of credibility that we accord them. So, for example, even us talking to you today, you may judge our credibility based by probably our work. Before you invited us, the organizers probably went online and searched, and there's something that they saw, which then they made a subjective judgment of whether we are credible speakers to be speaking today. And therefore, journals do mediate these. The other thing is that your credibility, by extension, also influences on whether or determines your influence on policy. So people who influence policy are more likely to people who are experts in their field, and therefore they are considered credible. And then that's why they are able then to change policy, and even to have other people who are responsible for implementing this policy to adopt it. Authorship is bread and butter of researchers, and therefore journals, by virtue that the ones that carry these, they directly influence these, since they make the judgments on whether to accept certain manuscripts or to reject them. And journals are not the same. Those which are rated highly and those which are rated less highly, and this has an impact on all these. journals, therefore, based on the things that I've talked about, they therefore have the power to impact the career progression, future grant income streams at both an individual and institutional levels. And it's the case that one's publication record is a key metric or in academia. I think they call it H index or something, but it's related to individual researchers in their field. We were able to see the number of citations their work has accumulated, and this can be codified into a number or that then you can use to see how influential this person is in their field. Authorship of academic papers, especially in elite journals, is therefore a currency that can bring career advantages, not only in academia, but even in the broader global health ecosystem. So now next I'm going to show a diagram that shows the position and power of journals within the global health ecosystem. And I want to ask a question to the audience that's here. What does this, looking at this diagram, so I give you about 15 seconds to just look at it. But in summary, it just shows the position and power of journals within the ecosystem that is global health research. So feel free to unmute yourself and answer these. What does this speak to you? What is your interpretation of this diagram here?
Hi, I'll jump in. Something that strikes me immediately is across the diagonal, you have the HIC governments and national policymaker agendas in the top left, and then all the way on the other side in the bottom right is the local community and the clinical and policy contexts. And so there's a lot happening between the local community and the actual policymaker agendas. Is just like my first impression on that.
Thank you, Lena. Any other person, any other perspective?
To me, like I see that the journals are positioned in the middle, while I always think the research should mostly benefit the local communities, but they are not in the center of this diagram.
Thank you for that. Still have another minute to still hear perspective on this. Any other person seeing something? I may not be able to look at the chat. Maybe one of my hosts can help read what's in the chat if it's a response.
I can read what's the chat for you. It says, and the person who's saying this is Subin Park. There's a lot of connections between journals, high-income countries, whereas the low and middle-income countries are more of an input or subject, in my perspective.
Thank you. That's the beauty of such images, because all our perspectives are true, and they are all not the same, but they are all true. So this is basically a representation of the position of journals, and in summary, from my point of view on this other side, is that journals influence the ecosystem by two main ways. One is that they broker the research outputs. Research outputs, these could be, so research outputs are the publication that they accept and publish. And number two is that they also issue direct editorial statements. So these could be things like commissions, like, for example, the journals, I don't want to use their names, they have commissions that investigate specific issues, and they come up with these recommendations that then form the basis of what donors, high-income countries, or are prioritized for funding, or just basically they set the agenda for global health, so journals. And then the biggest influence on these journals, as you can see, are from researchers from high-income countries. Someone pointed out, not the local community, which you can see down there, with a very weak arrow showing a very weak influence on either the researcher or the journals. And once the global health research agenda has been set based on what is contained in journals or in literature, then this cascades down to what low and middle income governments adopt as their national policies and agendas, and also what now is implemented. So thank you for that. So now we're going to look at the state of global health authorships, now that we're talking about them. So how does the picture look like? There have been several studies, mainly in the last decade, which have analyzed the authorship patterns, and they have found interesting findings. One of them is that only half of publications from global health research partnerships were by a first author from the country of research. The other thing is that 1 in 7 publications do not have not even one researcher from the country where the study was performed. And this is referred as parachute research in global health circles. So this is about 15%, not even one author from where the research was conducted. And now trying to look at the number of authors and seeing if this makes a difference. So a study that analyzed about 16,000 plus articles, and these articles had 5 to 10 authors. So local authors comprise less than 25% of the authors in about 31% of the articles. So only 1 in 3 articles had about 25%. I mean, 1 in 3 articles had less than 25% of authors coming from the country where it was the study was done. And then of about 4,000 articles, which had 11 to 15 co-authors listed, the local authors comprised less than a quarter of the authors in about a third of the articles. So this is again the same situation as the other one, that even increasing the band of authors, still less than a quarter, less than a third of the studies have more than a quarter, have more than a quarter of researchers from those countries where it was performed. And about a study that looked at a big number of authors published, these are almost 250,000, found that about 40% of published authors were affiliated with high-income countries. So these are authors in studies that are done within global health partnerships. And then an interesting finding was that about 10% have a combination of a high-income country plus another combination. So it could be they are affiliated to high-income country and a secondary affiliation to either a low and middle-income country or an upper middle-income country, but joint affiliation. And this corroborates the first slide that I showed, that about half of all published papers or all authors are from a high-income country. And also one that I'm not included here is the most recent COVID-19 literature, which has also been under heavy criticism based on an analysis that showed that there were no African authors present in a fifth of papers that were published from the continent concerning COVID-19. However, I have to acknowledge that yearly trends indicate that some progress is being made, and that there is greater representation of African authors in the senior authorship positions with more recent years of publication. These are good developments. However, I need to caution that most of researchers from low and middle income countries are likely to publish in lower impact journals. So the trend just shows who was published, but it doesn't tell you where was this person published. And a secondary question that can arise from the fact that most of the low middle income researchers who are first authors or senior authors are appearing in publications which have or in low impact journals. It be because they are writing off against secondary aims. So the paper does not tell you whether this paper analyzed the primary aim of this project or whether it was a secondary analysis that someone maybe tried to patch up to have a publication. This is a graphical representation of what I've just been talking about. The light gray shows that there was no author completely from the country where the research was done. And the gray one shows that there was some local authorship. And the trend is that about 1 in 3 have less than 25% of authors from that country. This other one is a representation of papers that had no local author or the research parasitism, where from which countries were these studies done. The deeper colors show countries that had most papers that had no local author. Something worth noting is that most of those countries do not use English as their predominant language of instruction in the education system, and based on their colonial past. So most of these are either colonized by Italy, Portugal, or Spain, but not mainly. But the fact is that they do not speak English predominantly. So what are some of the forms of authorship inequities? Some forms include inequities due to commission. So these are like tokenistic inclusion as authors. And so these are given as gift or honorary authorship. And these are scenarios where senior and usually powerful individuals are added to research publications because of their influence, e.g. funding, rather than active involvement in research. Another one is omission, and this mainly affects partners from the low and middle income countries who are judged as not meeting the ICMJE guidelines. The ICMJE guidelines are guidelines that are adhered by most journals, and they guide on, and they just have four questions with a criteria of how to include authors or who qualifies to be an author. And in this case, these guidelines may be used to include or exclude, but in this case, they are used to exclude. In a tokenistic case, as the first example, then the guideline can be used to include. But the point here is that the spirit of the guidelines, the ICMJE guideline, that is inclusive, at least according to some of the editors that I've listened to. And also myself, right now I'm an editorial fellow in one of the journals based in the North. And therefore, I know that the spirit is actually inclusive, and you need to go out of your way to actually exclude someone. There's therefore room to recognize the contribution of some operational research partners, which is what most people in low and middle income countries play in global health. They play mainly at the operational level. And these include program managers, policymakers, and community members who participate in these global health research partnerships. So in general, contributions of non-academic partners should be recognized, but are generally absent also from authorship guidelines. There are things about inappropriate listing where collaborating partners are usually relegated to the middle with the first and senior authorship positions reserved for the partners from high-income countries. The next two forms of inequities are more abstract, but they're also very important considerations. The audience here refers to the location of the journals, their target audience, and also who is able to access them. When low and middle income country audiences are the audience or have no access, then it means whoever has access to these, then it puts them in a situation that is described by a Malian thinker called Diawara. And she says that every narration places the spectator in a position of agency. And this means that if you are the audience of something, then it means you're also in a position to critically interrogate it, to either identify misrepresentation, do something about it. I'm a fan of Harry Potter, and when I watched the movie, having read the book, when I watch the movie, sometimes I'm critical. I say, no, this is not an accurate representation of these. No, this one is not justice, or it means you're interacting with it, and that's what is described here. If the research addresses the local population and they're not able to engage with it, then it means they're also not in a position to do something about it. And if another person is the audience of this, then it means that that person is the person who's put in a situation of doing something actually about it. The other injustices can be summed as epistemic wrongs, and these one occur in the processes involved in knowledge production, the use of knowledge, or its circulation. And epistemic wrongs can lead to epistemic injustices if the knowledge that is held by people who belong to marginalized groups is systematically afforded less credibility, and if their interpretive or sense-making resources are not recognized. And such wrongs can lead to injustices if the people are prejudiced, or their interpretive resources, their interpretations are prejudiced, as I will show in the next diagram. So the choice of audience also includes something that I was talking to, or we were talking rather to the organizers here at the beginning, that even includes where the Decolonizing Global Health movement is most active. For example, now we are talking with you are students from high-income countries, and probably this is not the case from these conversions not happening in low and middle-income countries, and therefore this is putting you in a position of agency, but it's not putting another student in this country in such a position. And then so it becomes a vicious cycle, because you're most likely probably to come and do something to correct it, but then the other person is not in that position because they're not the audience. So this is just a summary of what I was talking about, but I'll skip through it. And it's just talking about these epistemic injustices. Testimonial injustice is whereby unpublished knowledge is deemed less credible, and the interpretive injustice is whereby marginalized people are not able to do not see their interpretations or the interpretive tools reflected in making sense of the world. I'll share these slides in the interest of time. And one example of this is the response to Ebola by the World Health Organization in the Central African Republic, I think around 2018. One of the causes that went around as the cause of the Ebola outbreak was that it was caused by super spreaders. So there was this narrative about super spreaders, and it was estimated that 60% of infections were due to super spreaders. And digging further, like qualitative studies found that the reason why this occurred was because the people distrusted the healthcare system. So if you showed symptoms of Ebola, you'd rather, run away to another place or city or stay at home because you do not trust the healthcare system. And the response therefore then by the global health community was found that, trying to demystify, the myths, not making people be more trustful of the healthcare system. But then an underlying issue that was ignored and which locals said was their interaction with the healthcare system during the colonial past, especially the Belgium colonized areas in Congo, of which the colonization there was really very, I don't have the right word, but it was brutal, a brutal colonial experience and interaction with the medical system, including treatment for sleeping sickness, and so there is a deeper history that informs the citizens' distrust of the healthcare system. But then global health practitioners and researchers then are not able to capture these, because then when they capture super spreaders and their qualitative analysis ends at not trusting the healthcare system, then that's what we mean by injustices in the sense of testimonial or interpretive injustices, or how these people make sense of their situation. So what are some of the things that we can do to address some of these things? I think, first of all, you as students are in a position that is unique. You are either, as a student, you are not yet, you are not encumbered by the system itself. So some of the things that you can do is to make this an important issue. So I saw somewhere that global health, or public health rather, is taking things that we find tolerable and making them intolerable. So how can we do this? Maybe it could be through commentaries, it could be through such situation as this. I don't know what you can do, but also through making the practitioners uncomfortable. Also, or maybe even the audience itself of global health research uncomfortable. So editors, funders, your professors who practice this. So having ways of making them uncomfortable of this situation. Also to network with other students. I see these, you mentioned several universities, and collaborating also with other students from low and middle income countries, reaching out. But then the other things that, if you go into the space of research, you're going to be researchers soon, is to have structured reflexivity statements for any publication that you send in. And this has many questions that then help you to critically, when you answer them, then you critically engage and are able to think about these issues that we are talking about. And I'm going to show those questions in a short while. The other thing is to decolonize our mental universe, which means we need to always be in a position of challenging our assumptions. And students are very good at this, or people in their early career. At the institutional levels, journals and journal editors have a big responsibility to leverage their formal power within scientific publications to promote equitable partnerships. And some of the things they can do is to require and publish the reflexivity statements. And we're going to show also the question that they can engage with. The other thing is to change policies to allow use of joint authorships, which already occurs, but not all journals, and also joint senior authorships. So this then is able to recognize the significant contributions that are made when research is done in a collaboration, and people contribute a lot to its ownership and to its ownership and to its implementation in various settings. And it's as simple as just having joint senior authorship positions. To diversify editorial boards, we're talking about if you have to critically appraise a reflexivity statement or to influence the audience, then you also the editorial board, so the people who are appraising these, if I want to know if this research is contextually relevant to my setting, then I need to have probably somebody from that area or a researcher from there. And then to address issues about costs and access by individuals, institutions, and policymakers in low and middle income countries. It's strange or paradoxical that a policymaker in a low and middle income country cannot access a journal that has findings from their setting and has recommendation on what they can do, because the government does not subscribe to journals, and people may not be able to also individually have access to those. because the institution don't have an institution access. But then this is also linked to the whole publishing model, which is probably a different conversation altogether. So now some of the questions that we're talking about reflexivity questions include questions like these that have been developed before by some authors. So some, I could read maybe a question, for example, let's say, I could read like research management here. So how has funding been used to support the local research teams? So answering that, then you're able to assess the merit of this paper. Or how does this research address local research priorities? So if the author has to answer this question, and you can think if they know this question they're going to answer, even before the study starts, then that may actually, they may want to do something to be more equitable. These are also other questions that authors need to ask. Sometimes they can answer, they don't have to answer all of them as yes. For example, has the project contributed to improvement in local infrastructure? It could be no, but then they're able to explain. The other thing is what journals can do. These are some of the questions that editorial boards can engage with, but it's just implementing what was in the other questions. Then at the structural level, funding agencies play a very important role. In Swahili, there's a saying that says bendera hufuata upepo, which means direct translation is the flag follows the wind. So global health research sometimes just follows where the money flows are. If it's in HIV, then you find that most studies are focused on HIV. Right now, we are shifting to non-communicable disease, and you'll see most global health work going there. So funders have an important role to play in changing policies. And these policies can improve both institutional and individual competencies of researchers from low and middle income countries. And once you improve institutional and individual competencies, then you're able to influence their authorship footprint. Yeah. One example is in indirect costs. So indirect costs are overhead costs that are paid to institutions. If you get a grant of, say, 1 million, this grant is based on your research budget, but then funders usually give overhead costs of a certain percentage based on that. So other than what has been funded for the research, then there's an indirect cost that is given to the institution. High income country institutions get about 50 to 100% of indirect costs. So if it's 100% means if 1 million was for the study or research, another 1 million comes to support overhead costs. And this could improve infrastructure, training opportunities, etc., depending on their priorities. But for low and middle income countries, some of this funding is fixed at less than 10%, around 7%, and it's fixed. So such a policy, then you can see that impacts on the competency of institution and individuals. So I'm going to stop there and bring in Professor Bukusi. Professor Bukusi has a long experience as a researcher, and she has established long-lasting collaborations, including where I work, for more than, which is approaching 20 years. And she's someone who has been instrumental in strengthening the research ethics regulation backbone in Kenya. And he's probably the person who has the most publications in this audience today. So let us give her time to speak, and then we go to question and answer session. Apologies for if I've gone over time.
I won't take too many minutes. I'll just take a few minutes to highlight a few things. Now, I've been working in research for 30 years. So some of you probably weren't born when I was starting to work in this field. And I just want to mention a couple of things just on top of what Dr. Mogaka has mentioned. One of the challenges of people working in low and middle income countries is the time to actually write. Because a lot of times, and Dr. Mogaka mentioned this, they're in the trenches, they're in the field, actually doing the research. So they do the work, but then there's no time to write because you're actually working. But the person who's based in the other countries, in Europe or in America or wherever else, the data is coming in, but the person who's in the trenches in the field doesn't have time to look at it, to review it. And then most funded work, once the data collection is over, people don't fund you to write. They fund the work, but they don't fund you. And it's very rare that people will allow you a tail end of time to actually do the writing. So that really becomes a disadvantage. The other thing I wanted to mention in relation to this writing is just the challenge of being able to ensure people are trained to write. For many low and middle income countries, we have cultures that have a lot of oral discussions, oral dissemination. Information is passed on from one generation to another by people talking to each other, engaging and networking. Not all of it is written. Some of it is written, but not every single bit. And then if our educational systems do not strengthen the writing, they look at content, but they don't strengthen the writing styles, ability to be able to truly express yourself well by the written word, which is given the highest amount of currency, then the low and middle income countries lose out. And again, that then colonizes and shifts power toward those who have been trained and taught to write. Because we say, if it's not written, it's not done. Whereas in a lot of our local communities, the question isn't whether it's written, it's what was the impact? What did you see? Did you show that it could be done? And so just documenting it is not the evidence that it could be done. And so because we place such a high value on the written word, it's been written, it's been published, it's available in the public domain. And therefore, in that sense, we continue to perpetuate this whole idea of, unless you have the power of the written word, you don't have the power at all. The last thing I will say, and then we can go to question and answers, is just ensuring that even when information is provided, that it can be utilized locally. There is the weight for the international big powers, WHO. Have they made a decision? Have they sent guidelines? What have they said? This is typically played out in many instances where countries will say, we can't license a certain product unless it has this amount of efficacy, or unless the study has actually been done within this population, within this particular country. Now, what happens if whatever product it is that we're talking about, it can make an impact. And when you look at the population side, then you look at the bigger picture. And I'll give examples of, for example, when we're thinking about something like the dapivirine ring and its efficacy, it makes sense in places where there's a very high incidence of HIV. Maybe it doesn't make sense in populations where the incidence is much lower, the risk is much lower. So its population attributable effect is a lot lower. How do we then ensure that guidelines that we're waiting for from the bigger, powerful, more international bodies truly make decisions that impact those who truly need it in the spaces where they need it, in countries that have less of a voice or have less opportunities to do the research, but have a real need? So I want to leave it at that so that we have enough time for questions. We just have about 11 or 12 minutes. And so, Lena, can we pass it back to you to moderate any questions? And thank you, Dr. Mogaka, for really capturing very well all the issues that we had hoped to be able to discuss. So over to you, Lena.